Hello and welcome to ID Talk, Answers from an Infectious Disease Expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and a leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. Well, this is the week of October 5th. The United States is up to 7.4 million total cases and just over 209,000 deaths, plus the president himself has become infected. Data from the AAP, recruiting from all reporting states, identifies 658,000 cases in children, which is a rate of 874 per 100,000 children. In Arizona, we're up to a total of 29,744 cases of COVID-19 in patients birth through 20 years of age. That's 13.6% of the total population. Our rate is 1,618 per 100,000 children. Again, with the caveat that includes young adults ages 19 and 20. So our numbers overall are trending down, although we continue to have hotspots. In the country, there remain hotspots all over the place. So we are still looking at a long-term outlook of COVID-19 as a pandemic with anticipated surges or peaks and valleys for the foreseeable future. Today's questions, we have several involving a return to both school and also a return to sports. So let's handle that first. In terms of the metrics and the benchmarks established both by Governor Ducey and by the Arizona Department of Health Services, it appears that most of the school districts and the counties in Arizona have met or are close to meeting those metrics. Thus, there were active conversations about a return to a hybrid model of in-person versus virtual learning for school. Continued concerns have to do with transparency of planning for social distancing. Importantly, emerging evidence continues to suggest a greater than expected amount of aerosol transmission, not just respiratory droplet. That's important. Normal respiratory droplets, such as we might see with respiratory syncytial virus or even influenza, are large and heavy and typically drop to horizontal surfaces within 3 to 6 feet from a normal expression or a normal talking. However, if there is an aerosol component, that distance can be extended quite significantly. So the 6-foot planned separation between desks or between students or between classes, etc., is perhaps the minimum required for safety. And in fact, anything larger than that is going to be even safer. So that is, of course, going to impact significantly on spatial concepts for return to school. Even if one has half the number of students returning on any given day, it will be difficult to preserve social distancing within hallways, for example, or in the classroom. Similarly, the necessary requirement for masking remains, but the difficulties inherent in enforcing that remain quite significant. So what about those students who are known to have had COVID-19, whether it's a symptom with confirmation by nasopharyngeal swab testing, or even known exposure followed by symptoms, or whatever the diagnosis happens to be? Currently, for normal return to school and a removal from home quarantine, those students, as before, need to have been 10 days out from day of diagnosis or day of onset of symptoms and be fever-free for 24 hours. That may be new from the last time we talked. It used to be 3 days, then 2 days. Now officially it is 24 hours fever-free without taking antipyretics. So typically by the time any student, or adult for that matter, is 10 days out from diagnosis, they're likely going to be acute symptom-free, including fever, cough, myalgias, the whole 9 yards. That is different, or that recommendation is different than for those students in whom we're considering a return to or a start of athletics, of sports. And in that case, for students who had mild to moderate disease, the minimum time from onset of symptoms is 14 days, and an expectation that they no longer have ongoing symptoms, including fatigue, chest pain, palpitations, dyspnea, shortness of breath, etc. So the AAP has a fairly clearly stated set of recommendations, and it goes, if I may summarize, as follows. For a student athlete who had severe or critical disease and or diagnosed with multisystem inflammatory syndrome in children, a MIS-C survivor, the expectation is that 100% of those student athletes will have some degree of myocarditis. Thus, recommendation is that they not return to school sports or any sports for 3 to 6 months minimum from time of diagnosis. And they all would benefit from referral to pediatric cardiology, evaluation by EKG, echocardiography, 24-hour Holter monitor, telemetry, the whole 9 yards. So those are, and luckily it's a small population, but those are children who deserve very careful, very rigorous attention before any approval to return to sports. However, the vast majority of our student athletes will have had minimal, no, or at most moderate symptoms. These are students, again, who at the very least must refrain from athletics for 14 days after onset of their symptoms. And depending on the severity of their course and also depending on any persistence of cardiorespiratory symptoms, may deserve additional evaluation. So the recommendations from AAP, and this makes sense to me as well, are that those student athletes who had a moderate course, and we'll say fevers, myalgias, some degree of cough, shortness of breath, pharyngitis, GI symptoms especially, those are students who at a minimum after the 14-day quarantine period deserve an EKG. And specifically, we're looking for increased parameters in the lateral leads, which might suggest left ventricular hypertrophy. Keeping in mind that some of these students are also having right-sided cardiac disease, I would suggest any abnormality on the EKG in the office would appropriately suggest a referral to cardiology for further evaluation and testing. So that is for the student who had some degree of symptoms, moderately ill. Even the student who had mild or no disease whatsoever, but still has some degree of cardiorespiratory symptoms. And here I include exercise intolerance, dyspnea on exertion, shortness of breath, anything resembling orthopnea, chest pain, palpitations. Basically, set the threshold very low. And any student athlete who has any symptoms of any kind, which might suggest cardiopulmonary involvement, deserves at the least the EKG and strong consideration of referral to cardiology for further evaluation. That student athlete who had mild or asymptomatic disease, who has zero symptoms whatsoever at the end of 14 days, and examines normally in the office and has good follow-up, and is basically whatever your threshold of comfort is, that is a student who could potentially return to athletics without further intervention or further evaluation. So it's complicated, I know, and depending on which referral for a pediatric cardiologist one is using, there may be more or less involvement. But basically, as with any student athlete, our judgment has still got to be the most important part of the assessment. And I would add to that, though, a very low threshold to do an EKG on any student. So that is the return for athletes. That's the return to school after having had COVID-19. How accurate are the tests currently? And a specific question was asked about the COVID-19 antibody test. Well, the total antibody, which sort of includes IgG, IgA, and IgM, may be suffering from some false negatives. And that's just based on completely anecdotal experience that patients that I have managed who had classic evidence of a multisystem inflammatory syndrome in children were total antibody negative and yet had every other permutation or finding of a MIS-C child. So if one's referral lab, a reference lab I should say, is doing the total antibody test and you have a strong suspicion of active or recent past COVID-19, the test to send then would be specific IgG to the SARS coronavirus 2. So I guess that's a long way of saying that there's going to be some false negativity to the antibody testing. Also, it depends on when in relation to illness you are testing the child or the student. And if it is in the first 5 to 7 days, that student or that child is more likely to be PCR or antigen positive from a nasopharyngeal swab, certainly in the first 5 days of illness, and potentially may be negative for antibodies. It takes, on average, about 7 days for detectable and sensitively detectable IgG to develop to SARS coronavirus 2 after initial infection. So, assuming though that you have a patient who had a illness, a febrile illness, or something suggesting COVID-19, it's reasonable if they are at least a week out from onset to be doing the antibody test, and if it's an IgG-based antibody test, to put a fair amount of confidence in the result, positive or negative. How long do the antibodies persist? Well, there's still a whole bunch of debate in the literature, which unfortunately is mostly stemming from adult testing. We don't have a huge amount from pediatric studies, but the adult literature would suggest that those patients who had mild or asymptomatic disease may become seronegative, meaning antibody negative with the routine tests, anywhere as near as 2 to 3 months after their supposed onset of disease. That does not mean, however, that they are susceptible to new infection. Those patients still have neutralizing antibodies, and they still have T cells, T lymphocytes, and B lymphocytes, which can be escalated in response to a new challenge. Yes, there are a handful of patients who have confirmed new infection with SARS coronavirus 2. Those are patients who are at least 3 months out from their initial infection, and their repeat infections all have been mild or asymptomatic. So yes, antibody protection can wane. The severity of the initial infection probably has a large amount to do with how detectable and how long detectable the antibody test is, and then any theoretic risk for repeat infection. Huge caveat, we're still learning almost on a daily basis the immunologic behavior of this virus, and there may be additional markers or factors, I guess, which may affect how long somebody's positive and whether they're protected. So stay tuned for more. Other tests, I think we've all seen an evolution of antigen-based testing, rapid testing, in-office testing, and specifically the product which most people are looking at or maybe already have in practice is the Abbott Pharmaceuticals test, which is an antigen test. The positive predictive value or the positive specificity of that test is quite good. So a positive Abbott antigen test is very reliable. That patient, that child, has recently or currently has COVID-19. However, a negative Abbott antigen test needs to be repeated or performed with a different type of test, a PCR-based test, if you have a strong clinical suspicion for disease. The negative predictive value, the negative specificity of the Abbott test is nowhere near 100%. And that's pretty typical. Issues of technique, issues of amount of antigen detected, issues of where the child is at in relation to first infection and expression of infectious antigen. All of these are going to pertain into how sensitive and specific the antigen tests are. The PCR tests remain sort of the gold standard, with the same caveats that technique remains an important factor in how good they are. Fortunately, studies are now showing that saliva as a specimen versus the healthcare worker administered nasopharyngeal swab have similar detection rates and similar outcomes. So as we progress into further community-based testing, a saliva-based PCR test appears to be a reasonable way to go and avoids I'll use the word torture because I've had a couple of these now, the torture of having the NP swab up the nose for a count of 10 to 15. An important question has to do with neurologic either complications or associations, and specifically this questioner asks whether we have seen an increase in Bell's palsy, seizures, or neurologic symptoms after or in association with a COVID-19 illness. This is a fabulous question to which we, of course, don't have a great answer. The short answer is anecdotally, yes. I have heard from community pediatricians in Tucson, and I imagine so too in Phoenix and other parts of the state, that there are a couple patients who have a typical Bell's palsy onset in a timely or a temporal association with COVID-19. This is in no way proof of cause or effect. However, there is also emerging reports in the literature and anecdotally in the adult population about an increase of Parkinson diagnoses far greater than expected And again, this is in a temporal association with areas of the world that also have COVID-19 outbreaks. So, proof of causation, absolutely not, but certainly it is something to note. So I would not be surprised were I to have a patient who had known, proven, or strongly suspected COVID-19 disease, who then develops some neurologic illness, whether it's Bell's palsy, new onset epilepsy, a focal palsy, a focal weakness, you name it. It makes sense that there could be a causal relationship. Certainly, it has been shown by autopsy data that SARS coronavirus 2 does have neurotropism. So patients, adult patients typically with COVID-19, are presenting with focal deficits most often related to stroke. Certainly, the coagulopathy and the thrombotic events associated with SARS coronavirus 2 infection can affect the brain as they can affect other organs in the body. There does seem to be larger than expected numbers of adult patients with strokes and with central nervous system hemorrhage. So with that in mind, it makes sense that in the pediatric population, we too might see neurologic complications. There's a whole bunch of hand waving here only because there is just no data. Thankfully, there's not much autopsy data to look at pediatrics. That's a good thing, but it also means that we're diagnosing blind. So my very short, very long answer, but a very short response is yes, maybe. How about that? There could be neurologic complications, including Bell's palsy, associated with COVID-19. So that's where we're at, folks. This is the shorter one. I think certainly locally we're all looking at lower numbers, but still keeping quite aware of that possible child with MIS-C or severe disease out there. I suspect that we're settling into the long haul, looking at little flares of COVID-19 clusters in adults, which will secondarily affect school children and student athletes. And our job is rapidly becoming to detect them, to provide supportive care, to consider, yet still, remdesivir and dexamethasone for those who are severely sick, i.e. Hospitalized with respiratory failure or emerging respiratory distress. All the other children, and this is the vast majority, are having mild disease, and then our job becomes to diagnose, effectively advise quarantine, and then advise on safe return to school and also to sports for the student athletes. So thanks for listening to this shorter ID talk. Please feel free, AZAAP members, to submit questions for future episodes to COVID, COVID, at azaap.org for more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Thanks for listening. Be safe. Be sane.